Just to remind people, we're going to have a dialogue amongst the panel that will be stimulated by questions that I ask. And later in the session, we'll open up the floor mic to questions and questions from the web as well. I'm going to ask a hard question, and maybe this will take care of the whole session. And it's it's based on what all three of you said. So I just made this question up. Is that okay? We talked about intimate partner violence and sort of assessing risk and mutual risk. And Christopher talked about points of contact. And David starts with the right person, the right time, the right person, the right place, correct? So I'm sitting here thinking about this, and I'm thinking about sort of the trajectory of how you get to a firearm injury. And I think actually, when we think about the right person, the right place, the right time, it's also the right intervention the first time is what we want. So I'm interested in how the panel, you allude to this, and I think in your sophisticated algorithms, David, but how is it that we really hone in on the right person, the right time, the right place, but with the right intervention? So I'll just put that on the table, and whoever would like to go first, please do.
I think, from my perspective, it's going to need to start with identifying when is it relevant for us in practice to evaluate that risk. So identifying those patient contexts, those patient presentations, where it's relevant for us to inquire. And that would be the first step to then developing the second.
Are you clear as a clinician? I love asking questions, so I'm glad I don't have to answer these. At sort of the right time, the right clinical encounter, what the intervention should be?
No, I don't know what the right intervention is. That's what this is all about, because we don't. So it's about the process of getting there. And I think when we actually have a more robust and comprehensive view of the problem, we can calculate its burden better. And we can also calculate the costs better so that we can make a better case for funding. If a healthcare system, one thing, I don't know, Kaiser, if this happens to you, but some of the patients that we receive in the department, and this is not just Vermont and Massachusetts and New York, but we have to board them in our ERs. And some people are boarded for literally weeks, and then they have involuntary psychiatric hospitalizations. So some of these people who are at risk of perpetrating gun violence have mental health costs that I don't know of anybody assessing. Maybe if those numbers are captured with their length of stay, then there'll be more impetus to evaluate that part of the problem better.
Thoughts?
So I think that is the point in terms of what we're hoping to get out of the two-day session is for us to begin to break the ice around what is the right intervention, because I agree with Chris that clinicians don't know what to do. And I think everyone's doing something different. And there's two reasons for that. One is we don't have evidence, and really strong evidence around what is the right thing to do. So clinicians, to the extent that they're guided and trust evidence as the basis for their practice, don't have that compass. And I would venture to say that even in best practice, there's been a lot of work that's been done around universal, particularly as a fellow pediatrician, there's been a lot of work that's been done around how to communicate with parents around children and guns and what to do. I think probably far less so, but I would defer to Megan on the IPV part, on the apartment violence part, but I think in suicide as well, and I'd love to hear from those in mental health in the audience. But in general, there's an absence, and this is at least from Kaiser Permanente's part, this is the void that we want to be able to take care of, is through research and innovation, is to figure out and collaborate with other health systems that have similar interests in wanting to do this together, because we can't, we have to learn this fast.
This is the right question, and I also don't have the answer of what the intervention is, but I do think We need to kind of learn from prior intervention development. And, I think healthcare has a really important role here. It was a slide that Chris put up that the man was brought to the hospital, that our reach is sort of incredible. We see just a lot of people, and so we have this opportunity both for identification, for prevention, and for intervention. But I think what gun violence, and when I thought about intimate partner violence, is a little bit different than cardiac disease. This is a multidisciplinary problem, and I think if we think about solutions, and it gets to David's point about sort of right person, right time, right place, we have to be a little bit humble about who are our partners in thinking about this intervention, who are the community group organizations who really know this world, our partners in mental health, our partners in law enforcement, because whatever that intervention ends up being, I don't believe health can do it by itself. And I'm not sure, again, it depends on your setting, but the moment of the injury may not be the right time. And so I think we need to think about this a little bit differently than we would an intervention for cardiac disease, which also
Actually, perhaps a corollary to the question that you asked, Therese, is what are our expectations right now for those interventions?
Hard one. And we will have panels on interventions tomorrow, and that's tough. So I'm going to recast just for a minute the identification of higher risk. And maybe I'll start with you, Megan, since you talked about intimate partner violence. Do we in health systems and as healthcare providers equally attend to identifying a victim or recipient of intimate partner violence risk with a firearm versus the person who is applying that risk? Are we screening both ways, and should we?
I would say no. If you look at all of the work for intimate partner violence screening, there's much more for survivors of violence than there are for perpetrators of violence. It's a really nascent field. There are sort of a few folks who are courageously thinking about how we assess for risk of perpetrating intimate partner violence. And similarly, I think we need to think sort of within that field, if there's somebody who's using intimate partner violence, are they at risk of escalating that violence? And I think in the research world, we are far behind where we are in identifying folks who are survivors of violence. And frankly, sometimes it's the same people, and so we need to be cognizant of that. The same people are using violence and experiencing violence, but I think we need to think about both.
Yes, I wonder if other people have thoughts on that. So I think of situations where you have a patient who is a heavy drinker, for example, and it's hunting season, right? And we know the risk of alcohol in hunting and shooting somebody other than the animal you're shooting at. Should we really be broadening how we think about identifying higher risk people?
I do think, yes, I do think the answer is, so there's no, first of all, as I tried to indicate, we're probably stuck at univariate risk for a while, at least from thinking about, we assess risk separately for depression, intimate violence. We look at these as individual univariate behaviors or processes. And I think that what you're getting at is important, which is that when we think about firearm injury, we have to be thinking of it more as a syndromic issue, not as a disease issue. So that the situation of a perpetrator, an adolescent perpetrator carrying a gun to school, that's so vastly different than the issue, I think, from my perspective of a victim from an intimate partner violence or an older adult in suicide. I think these are, and for our purposes of trying to understand what are the right interventions, they have to be situation specific. They have to be meeting a sort of a syndromic or a situation specific criteria, because that's what the clinician's sitting in. I mean, the clinician's sitting in that specific circumstance. Your example of a hunter who is known to be have problems with substance misuse is a good example for primary prevention, because that's likely when you're going to get that person, and would pop out in some sort of comprehensive view of a combination of doing an audit, part of audit screening for alcohol misuse, and in addition to understanding what that person's, behavior is with regard to use of firearms. But this is going to take some real work to kind of trace out what are those. And I think we would be smart to identify what are the big buckets. What are the really big buckets? It's probably not going to be the hunting accidents that would be the big buckets. It's going to be IPV, it's going to be suicide, I think, and that's my bias in that way.
No, I agree. It's just, as a community practice physician, everything, what diagnostic question that we pursue in the mental health assessment is entirely dependent on context and collateral history. So is there a specific structured interview that we can create about firearm risk amongst patients who present with any sort of mental health disorder, or any child that presents with a certain kind of accidental injury that would suggest that perhaps there would be firearm risk, for example, being shot by a BB gun? Could we create a more robust and more accessible risk assessment tool for physicians who, there's a MacArthur tool, and there's also Waiver 21. There are some very elaborate risk assessment tools that are very cumbersome, but is it possible to create something like that can help us at least identify or start the screening process to go from, okay, what is the risk? Is it low, moderate, high? Because the high, we got that down. The low, we're okay. Is that moderate? Like, how do we then fractionate the moderate risk into categories so that we can refer it for more study?
Great answers, guys. Now I'm going to ask another big ticket question. How's that? This is going to be a hard one. I'm not going to open the floor for comments quite yet. I'll tell you, though, when. Is that okay? I'm in charge. Okay. But I promise you'll have an opportunity. All right, so we're talking health systems, right? So from a health systems perspective, what do health systems need to put in place for providers to look for, recognize, screen for risks, identify higher risks? What has to be in place? What will facilitate providers actually doing this as part of their practice?
I'll take a stab at that. I think to get providers on board requires probably a couple of different things. One is that clinical guidelines would be a really good starting place that are based in evidence and continuously revised based on the emergence of new evidence. And they should be tailored. They should be tailored to the site of care. So clinical guidelines for ED providers versus primary care providers, for example. The second is that they have to be embedded in workflow, and they have to work for the workflow of the clinician. They can't be just, and to that extent, when we implemented a dental fluoride varnish program within our system, there was a lot of uncomfortability among our clinicians around, like, we're not dentists. And the way we sold it to our pediatricians and our family physicians was, you do immunizations, right? And I said, of course we do immunizations. And I said, well, you use your flow staff to do immunizations, right? I said, of course, yeah, we do that. It's like, you do examinations, right? Yeah, of course we do that. Well, all you have to do is examine the teeth and refer to your flow provider to actually administer the fluoride varnish. And think of it as an additional immunization because you're already sending them for immunizations to that same provider, and they can just do the varnish, almost like rotavirus vaccine. It's just another oral thing. So people needed a paradigm to grab onto to make and then understand how it would fit into their workflow. I can't overestimate. I can't emphasize enough how important it was in that regard, and I think this will be in this regard. The second is provider self-confidence in addressing the topic. My colleague Nancy Sugg, who was in my fellowship program 30 years ago, did a JAMA paper on intimate partner violence, and I think the title, as I recall, was Opening the Pandora's Box. And it was a qualitative study that, and I think this was alluded to earlier and by one of the speakers, qualitative study really understanding why providers weren't asking, because they had no confidence about what they would be doing afterwards. So the providers really have to be able to have that confidence. And then finally, I would say, that the system needs to be able to know, the system has to be designed to be able to make it easy for the clinician to do the handoff, and Chris just alluded to that too. So that, so who is going to do that follow-up work? Who's going to do that intervention? If you burden the clinician with everything, then you may not be successful in terms of the outcome.
Those are exactly what I would say. I think confidence in assessing for risk. I think most of our physicians and other providers aren't trained to do this, and so feeling okay about having those conversations. And then I think providers aren't going to do anything unless they feel like there's an intervention that will be efficacious, and so there has to be the intervention piece. I think the one thing that doesn't get discussed that's important to bring out as well, it's the AHRQ, the fourth of it's now the quadruple aim instead of the triple aim, which is burnout. And these are really hard conversations, and these are really hard cases, and I don't think we do enough in the healthcare field. I think our mental health colleagues are much better about this. Actually, I think that nursing it tends to be better than physicians, about talking about vicarious trauma, about processing some of these cases. And so I think for our system to change, we have to build these supports for our workforce as well.
But all this is going to be predicated on building a new paradigm, because I don't think that most of us in clinical practice have an understanding, have our brains wrapped around our opportunities for intervention. I mean, most people that you talk to about gun violence prevention, they'll mention trigger locks, which certainly have value, and lethal means restrictions with suicidal patients, but they don't know exactly how to advise them on that. But 40, 50 years ago, we as physicians didn't have this construct of child abuse. It was beat up kids and bad parents. And then over time, we crafted this child abuse that now we actually have interventions that are elaborate and layered, and we've seen a decrease in the severe child maltreatment happening. We're at that point right now with gun violence. We have to create a new paradigm on which to build and wrap our brains around this.
I would say that the paradigm has been partly built through the advancements in behavioral medicine. And it was discussed earlier around tobacco cessation, our ability to actually, clinicians I think are starting to wake up to the idea that not all interventions involve a needle or involve a scope. That talking therapy actually does work, and that motivational interviewing works. It works for alcohol, it works for depression, it works for tobacco, and works broadly across changing a number of behaviors. It's an area that I think that if you can graft on this paradigm to the extent that some of these interventions might involve changing in behavior, then we might have a chance, at being successful with that. But to your point, I think primary care docs are actually probably more comfortable living in that domain because that, they're being much more exposed to that than perhaps specialty doctors are, in part because these are predicated around screening interventions that lead on to a follow-on intervention.
Should we have the identification as systems think about how do I put in place aspects or components, structural components to really allow that risk assessment to take place? Should that really cross all aspects of the system? Should it focus primarily on primary care? Should we just say, let's not pay attention to the specialties right now? Where do we get the biggest bang for the buck?
I think that, like child abuse, whoever encounters the person at risk or who has a suspicion then refers. So obstetricians, general surgeons, that construct to me makes a lot of sense, and it demonstrates that we have one part of this puzzle to solve, and we don't work alone. We need to have social constructs and policies that help us. And a number of states, including my home state of Vermont now, has operationalized extreme risk protection orders, so that in the acute setting, when we recognize a tremendous risk, there is an intervention that somebody else can do. Like our job is to treat the patient and to address whatever modifiable risk factors can be addressed, but the separation of lethal means from the individual is the part of law enforcement and family to make that happen.
So if you have providers in your health care system who say, this is just not my job, like gun violence, screening for risk for gun violence is just not important to me. I have many other gods to pay, and we talked about embedding it in workflow and making it really easy, et cetera. What other things? Competence, I think we talked about confidence, provider confidence. What other things should we really consider to bring those providers on board to say, this is your role?
This has happened for years within domestic violence, and I don't think we've won this battle because there are people who bought in really early that violence is a core part of what we do. There's some late adopters who are coming around, and there's some people who will never think that this is part of what medicine should be doing. And so I think it gets a little bit to what Chris was saying. We have to have a comprehensive response as a system. When they've studied there was a systematic review of the most effective intimate partner violence interventions in clinical settings, and kind of the key finding was that the most effective interventions were ones that involved everybody from the front desk person checking the patient in, through the nurse, through the MA, through the provider, through the medical provider. And so I don't think this is just a physician thing. I don't think this is just a nurse thing, because we're never going to convince everybody that this is their job. It has to be a multi-layered system that everybody owns a part of this.
So I have maybe a slightly different point of view, which is I talked earlier about the creation of clinical guidelines. Guidelines are the foundation for behavior, professional behavior. And I think that in integrated health systems, the importance, and particularly in a group like ours, the Washington Permanente Medical Group, which is the group that works with the Kaiser Permanente Washington region, culture means everything. Culture is key. It's key at places like Health Partners, where George comes from, where your ability to instill a physician culture or a clinical provider culture that understands that we have certain professional norms and responsibilities and accountabilities. Those are determined with broad input and evidence, but that there are rules about what we expect from people, and I think those are things currently in Kaiser Permanente Washington. We're through a behavioral health and integration initiative, we've seen the PHQ or the patient health questionnaire screening go way up. And that's through a regimented process of really saying, here's how to do it, here's what we expect of you, and by the way, we're going to start measuring how you're doing, and we're going to give you that feedback, and we're going to give your chief that feedback too. This is your job. So that's kind of part of what we would, in our culture, we would expect to be able, and that's how we were able to implement these things. When we did fluoride varnish, we gave every doctor a card, and boy, did they vary a lot at the beginning in terms of who was on board. It's like the enthusiasts were right on board, and then there was the people who were just like, I'm not a dentist, I'm not doing this. But after sufficient feedback, people eventually were able to get on board. I think it is about the culture.
So you would measure and, you get negative feedback essentially, like your reports are not so good. I was almost thinking, I'm not putting words in your mouth, I'm just verifying. I come from a hotbed of behavioral economics, like can healthcare systems incentivize providers? So is it like a positive valence incentivize, or a more negative, like you're not making the cut? Any thoughts?
In our case, I'll just say
Megan.
It's about peer pressure.
I would say the one cautionary, I think this is all true, I think it has to come from leadership. I think we have to have clinical protocols. My caution is both as a patient, as a provider, JACO requirements in the ED that you ask about domestic violence. And here's what happens. A nurse going like this, okay, do you have HIV? You don't have HIV. You're not a victim of domestic violence. Are you? No. Okay. And then they've checked the box and their performance is great and they get the incentives. And that was not a conversation, so yes, that nurse has asked me about domestic violence. Would I ever disclose in that situation? Is that a meaningful screening? No. And so I think the culture and the guidelines are a start, but I think there's another piece of embedding, like what does it really mean? And I think sometimes people then feel the need to just check that box, and we have to make sure we don't go that way too.
All right, so how do we create that culture, that clinician-provider, the clinician-patient culture or environment where conversations like this take place? How do we create that within health systems? So it's not just I'm checking off the box.
Well, for one, I think that ideally intrinsic incentives are probably far more powerful than extrinsic. I'm personally a skeptic on pay for performance. By and large, I think it's been a mixed bag in terms of all of the work that's been done to look at the outcomes associated with pay for performance. But I think that appealing to what clinicians really value is seeing results with regard to their patients. And we have a harder task in prevention because in prevention, you don't see what doesn't happen. It's much easier to be gratified by a patient that heals in the trauma center after having and seeing the importance of the work that you did there. It's harder to see it when you're not. So I think there are various things that you can do to be able to say, look, this is how many, but using math and understanding what the effectiveness of the intervention is, you can be able to calculate or estimate, here's how many lives we've saved, here's how many firearm injuries we've saved, or you can actually measure the data to the extent that you have access to that and be able to point to that and make people proud of that. I think I think Megan's right, that ideally you really want to create appeal to the, because I think we're dealing with people who got to where they are by largely wanting to do the right thing for their patients.
And on that subject, physicians are very motivated by the mission of medicine, right? We all want to take care of our patients and their families, our communities, and to kind of help promote that ethos in this space of gun violence prevention. What are the current educational offerings for gun violence prevention? There aren't a lot. And even in our peer-reviewed literature, there aren't a lot of case-based narratives that will describe the opportunities where physicians may intervene. Perhaps there could be some movement to ask for and publish cases like that. I know Steve Hargarten mentioned that it was hard to find a case of attempted suicide that survived, but I have a lot. And I think if you were to ask rural docs in Upper Peninsula, Michigan, and Arkansas, and rural Vermont, you get your cases.
We're talking about identifying higher risk patients, but we're also talking about protective factors, right? So it's a balance, right, between risk and protective factors. How do we really find that balance and bring in the protective factors? And do we have good ways to measure protective factors, things that would protect one? I think of suicide, for example. Like, how do you decide, do I send somebody home? Do I keep them? Are they at risk? Or interpersonal, any kind. Like, how do we balance that and how do we measure that?
I don't think there isn't a reliable quantitative measurement for that. Even the best ones have limited sensitivity, so it's going to take experience.
Yeah, it's tough from a clinical risk assessment. First of all, clinical providers are always just trained to go for risk rather than protective factor. But in this particular case with firearm injury, there are factors that probably matter in terms of assessing access to firearms. Protective factor, clearly would be what's the status of the gun with regard to being locked and unloaded. That's a protective factor. But when you get to individual, demographic factors or characteristics or behaviors, like Chris said, I think we lack evidence for the most part in understanding what that's about. Clearly, social support's going to figure importantly in some of these issues, particularly with regard to IPV or depression. But I think we have my sense is a pretty crude understanding of that to date.
Megan, is there anything we've learned from domestic violence that would help us when we think about that risk protective?
I think exactly what Chris and David have said. I think we've learned some sort of individual level, neighborhood level, community level factors that are protective when people are in domestic violence relationships. Everything from good mental health to social support comes out a lot in terms of decreasing isolation. I don't think we assess it well, nor do I think we know what the right interventions are to really enhance those for our patients.
One thing to consider too is that we understand that family and community give protection, and especially in rural America, firearm ownership could be the norm and not the exception. And so it's really important to engage people who are firearm owners in the identification of what behaviors are protective and which ones aren't. with respect to firearm ownership. For example, if a patient, I've been screening for firearms amongst my patients for years. I've never encountered a political discussion on that. And every time there's been somebody who's been perceived to be at risk by a family member, they take the guns away. And this is before the extremist protection order, and it's never a problem because they're all on board. So I guess if you start to evaluate, if you have frank conversations with firearm owners, you will learn what are the best protective factors for firearm risk amongst those populations.
Before I open the floor for questions, I'm going to ask each of you to identify one or two important research questions that we need to ask so that we can implement in the health system, in health systems, how do we really accurately identify higher risk individuals? What do we need to know? What's the next study we should do? And if they have no answers,
Like, what's my
maybe
favorite
as well.
color? What my favorite food? It's like,
Well, I think I personally believe that we have a significant amount of information about univariate risk that we can put to use without having to get fancy with multivariate risk models. However, having said that, it would be really important and helpful to understand at least putting multiple variables together, particularly around interaction of alcohol and mental health, for example, and to better understand a multivariate risk model about who's at highest risk for guns, and after adjusting for this confounding, for the confounding associated with the covariates in the model, to really try to better understand about what are the key variables that are driving that outcome. So we have gotten really good at predicting, I think, univariate risk, but not so great on multivariate risk.
20, but I won't say 20. I think one of the things we haven't talked about is as we get better at assessing and predicting risk, we talk a lot about screening instruments, and this was an issue in the field of domestic violence as well. People need to understand both benefits and risks of screening, and so if we have an instrument that we think can identify risk, what are the potential, not just benefits in terms of outcomes, but also risks for implementing that in a health system? And, just as an example, identification, we, when I was in Baltimore, talked a lot about assessment of escalating risk in domestic violence, and honestly got stuck because we were concerned that as we assessed risk or used the danger assessment and found out about a firearm, all of a sudden we need to think about reporting to Child Protective Services, and what does that mean for that family? Because in the pediatric setting, if we find out, depending on the state, you do not necessarily need to report domestic violence or kids exposure, but once we find out that there's a firearm, we didn't feel comfortable not reporting that, and so I don't think it's always clear. I think we think, the screening and identification is great, but we need to think about potential risks for patients as well.
and I don't have two, I kind of think of it not as a research question, but three buckets of where we can actually, three buckets where our research can go. And my job as a physician is to help define safety and to mitigate risk and then reduce harm. So reduce harm. So I think that our research, and there's thousands of questions that can get to that. But in particular, how do we get to that when it comes to mitigating risk? How do we still don't understand the trajectory of risk from low risk to moderate risk, so questions that focus on the transition point when risk becomes acute.
I just want to echo what Megan says and underscore how critically important the issue of understanding potential harms associated with any preventive service activity. So the U.S. Preventive Services Task Force routinely looks at harms associated with screening methods as well as any harms associated with treatment or the harms of any intervention, whether it's treatment or behavioral intervention. That is, and in IPV and important violence, the last review that was done around that found insufficient evidence. Frequently, that's the area where we come up dry. And the task force uses a concept called bounding, which is to really understand, well, the risk could be no greater than X for example, a screening questionnaire, that's the risk there is not likely to be greater than small, because filling out a questionnaire is not likely to be a dangerous thing. This is a different area. We're dealing with a dangerous instrument. We're dealing with dangerous behavior where the potential harms could be quite large. And so studies to understand harms are critical in this field.
Excellent. So I think one thing I think about as we talk is there's a temporal component to risk and protection, right? So there's immediate, there's escalating, there's risk that we see unfolding over time that we haven't even talked about, but that in primary care settings, for example, we should be thinking about as we think about risk stratification. So now you can stand up again. And now we'll open the floor for questions. So go ahead.
Yeah. Thanks for your presentation. My name is Li Yang, and it's good to talk about these issues, especially domestic violence. It's not only between the couple, it also affects their children, and they are all family, elderly relationship, everything. And what I heard is you think you are the physicians or medical professional, you don't have too much to do with their relationship between the couple, but I don't really agree because this system basically is money-oriented, and their couple relationship will be influenced or maybe destroyed by some unethical values, immoral value to destroy their family. So, for instance, maybe real estate professional who want to destroy relations so they can sell their houses. And then maybe some other professional accountant maybe destroy their relations so they can deprive of their assets and account. And maybe law enforcement can do this so they can send them to jail and then they take away all their reputation and money, assets, and other things, including the emergency services. So if the physician can, based on your ethical value, based on your important is proper processing of complaint or request or medical information, rather than ignore everything, so they have to go through other channel and go nowhere. So if we can, everybody based on their individual responsibility, whether you are a physician or not, we got to do it. We have to restore our society's fairness and value so everybody can live peacefully rather than being victimized. Everybody lost. So if you can address the issue, see if you can see what you can carry your responsibility to improve your profession, the way you have to handle your files, your calls, and everything that you can do. Thank you.
Thank you. Any thoughts?
I think the question was in part about domestic violence. This has obviously been my feeling. It's why I do this work. I think it's every medical provider's responsibility to understand about their patients' families, everything from healthy relationships to unhealthy relationships to domestic violence, because frankly, for children's health, it's really all about their parents' health and wellness, and it's where the biopsychosocial model, I think, needs to be a core part of our training, because there's so much obvious evidence about the impact of trauma and trauma exposures. And so I think it's everybody in the medical field's responsibility to incorporate this.
All right, George.
So I'm trying to figure out which of the many questions I have. So this is an important discussion, and thank you all for it. It's very, very helpful. David, you talked about, I believe the term you used was univariate risk, situational risk, where you have a situation, population, and one factor you're looking at. And then at another point in the conversation, we heard some not very clear discussion, but some mention of complex formulas for assessing risk, presumably in different situations or across the population. So I'm beginning to wonder whether the key question for this, a key question for this panel is, what are the populations at risk and in what kind of order, and how would you judge what kind of order for a health system to approach them? So I've heard the general population, for education and so forth. I've heard those previously injured by guns. I've heard intimate partner violence victims, and then some discussion of potentially the perpetrators of that. I think those in mental health treatment situations who are at risk of harming themselves or others. And I'm sure there's others, because I'm so much an amateur in terms of thinking about this question. But would you be thinking about identifying those populations in some kind of order, figuring out what the characteristics are by some set of criteria, and then trying to prioritize them? Or do we have to do everything at once? And will that succeed? So that's my question, my first question.
Well, that's a complex question. It's almost, if we wanted to go for low-hanging fruit to have a big bang in a health system, what would you prioritize if I'm can?
From my perspective, it makes sense to have a first go at a comprehensive discussion, and to then break down the populations at risk from that point. So go big or go home.
I might take a different approach. I think you could do that, or with limited resources and limited funding. David talked about a targeted approach, and with a relatively rare event. And so across those populations that you mentioned, and I don't know the comparative numbers, but who is at the highest risk of future firearm morbidity and mortality, and begin to think about an intervention for that group first, knowing that we'd probably learn for the other populations would be another approach.
Yeah, I would tend to go that direction as well. I guess, George, I think I would vote for prioritization, tackle a few things and do them well before trying to do everything. And I would take it in terms of absolute number of potential cases, the potential preventable burden, basically, is looking at absolute numbers. Relative risk, for suicide, looking at risk factors, for example, in depression, and trying to identify people who have depression through strong screening programs, and then further on, as Greg's team has been doing at KP Washington, using additional screening tools to understand what's their level of suicidal ideation, I think is a very promising path, given the relative risk of suicide, of depression is in the substantial double digits. So we're looking at somewhere in the 25 to 35 relative risk range, which is huge. Huge when you think about what the relative risk of death from homicide or suicide in the home from just having a gun in the home. It's still, from an epidemiologic standpoint, substantial. It's in the 2 to 5 range, but not when you're looking at something like 30 for depression. So I'd be going after people in that range, and then trying to sort out where can we make the maximum impact.
I want to qualify my former statement insofar as within each domain of violence, there is low-hanging fruit. And so I think that once we identify the population at greatest risk within each group and where the best opportunities lie, then we should try to roll out a program to capture all of the easiest, most readily identifiable populations.
I would just add to that, I think from the morning session, I tried to make the case it's important for each healthcare system to know their burden, right? So if I'm in rural Pennsylvania, I may have a very different burden than urban Pennsylvania. So if I was going to enact something in a health system, I want to really make that diagnosis for my health system and decide that maybe where I'd focus resources.
I'm Greg Simon from KP Washington. Since the expression came up this morning and this afternoon, I just wanted to put in an enthusiastic endorsement for box checking. And what I mean by that is, I think we now have compelling evidence that very simple multiple choice, yes, no questions, administered on clipboards or waiting room kiosks or by everyday medical assistants with not much more than high school training are very accurate in identifying people who are at high risk for self-directed violence or suicide. And since the healthcare system has a proud tradition of squashing the good enough for lack of the perfect, I'd say let's not do that here.
Thank you for your comment. Go ahead.
Hi, Bashara Shukair, also with Kaiser Permanente, and I was clearly tweeting and not paying attention to instructions, so now I know now is the right time to ask public comments and public questions.
Yes, now you can have the microphone.
This is obviously an extremely important panel about thinking about how do we identify individuals at risk. And to follow up on George's initial first question, clearly we heard a lot about screening, and I also heard from the panelists about predictions. So, clearly screenings is important. And as we think about prediction, I heard a lot of comments around using the data that we have on those patients, those members, to try to help us to predict who are at high risk of firearm injury. And I'm wondering whether there is a role for publicly available data that's not within the health system EHR. What would those look like? What is that role? Do we look at census tract data, poverty data? Do we look at consumer data, purchases data for individuals? I mean, how do we start thinking about big data beyond what health systems collect? And the reason I'm asking this question is as a health system, we've treated over 11,000 gunshot wounds in our emergency departments in 2016 and 2017. Can we imagine a day where we have an algorithm that would tell me, here are the 11,000 people who are likely going to be coming to your emergency department dealing with gunshot wounds, and let's think about the right interventions to be proactive with those 11,000 members so we can get to them before they end up being victims of gun violence in our emergency department?
Well, I think, Bashara, you are correct that we need to be more nimble in our use of external data than we currently are. But that's not easy. And certainly integration of data and linkage of data sets is increasingly more challenging. We do, for example, in our research institute, routinely link all of our enrollment data to death certificates. So we actually, even though that's not, we are using public surveillance data to actually understand what's going on in terms of death in our own population. But death is a crude outcome, important, but crude. And certainly in terms of use of other data, like National Violent Death Reporting System, which is not identifiable to my knowledge and cannot be linked. Unfortunately, we have some dead ends there. However, having said that, in the state of Washington, we have this new accountable communities of health process that's unfolding, where the state is empowering and funding clusters of counties within the state to take accountability for their own epidemiology and plan interventions respective to their own regions. They are pulling in all sorts of community-based data to really paint a picture, and that will include health data as well if it comes from the health systems, to really paint a picture of what's going on in those communities. That's, I think, a fairly promising approach to thinking about community-focused interventions.
I suspect that we have an understanding that many of the victims of gun violence are in a network of other high-risk individuals. So I suspect that by looking at social media data as it develops, there may be opportunities to identify higher risk people and perhaps add that to our decision-making process.
Thank you. Go ahead.
Yes, I wanted to respond to Dr. Merritt's identification of the impact or the effect of exposure to gun violence victims on the caregiver, the provider, and call to your attention, if you're not aware, and others. There's a documentary, Portraits of Professional Caregivers, Their Passion, Their Pain. It was nominated for a regional Emmy Award. It didn't get it on Saturday night, but Vic Comfort, the director, was quite honored to be nominated. It's excellent. It's gone across the country. It's received a number of awards. There's a trailer online that you can get to through Googling Portraits of Professional Caregivers, Their Passion, Their Pain. he's available, he and the artistic co-producer. It's beautifully done. It's animated with music and gives that kind of lift to very painful subject matter, but they are happy to respond to invitations to do screenings. They've done them at the University of Pennsylvania, I think in more than one department. And one of the advisory board members, Don Friedman, is a retired rheumatologist, and he's brought this also to the attention of the American Medical Association. He's done a number of workshops for physicians.
Thank you.
Thank you. I think that's incredibly important. I will go look that up and look at the trailer. But as part of the systems response, I do think this is a really important piece because this is a really difficult issue for providers.
And I forgot to mention something very important, which is in the city of Philadelphia, City Council will be holding hearings in December on this issue of secondary trauma in professional caregivers and first responders. And it was their action. Last February, they declared February 15th, Professional Caregivers and First Responders Day, and it was inspired by this film, so it's powerful.
I'm going to go you and then you. Go ahead, Cornell.
Cornell Cooper. About 2 decades ago, we started the hospital-based violence teaching program at the University of Maryland, and we would occasionally see a few domestic violence patients. And then about 8 years ago, the number went up. We decided we need to start a domestic violence program by itself, and we started getting about 100 referrals a year or so. Then about 4 years ago, we embedded in our EMR. And all of a sudden, we're getting 500 referrals a year, and we serve and from the ED, from the outpatient arenas, et cetera. So I wanted to ask what your thoughts were about putting such the screening process, EMR, and it was mandatory for closure. So you had to complete in order to close the record on the patient. So I'd be interested in your thoughts on the use of a EMR to screen for things like IPV.
I mean, I think it gets a little bit to the question of how do you motivate provider behavior and you include it into clinical flow. I think when you do that, though, to your point, we know 1 in 3 to 1 in 4 women over a lifetime experience domestic violence, and it depends on how you define it. If you include emotional abuse, those numbers can go higher. And so when you begin to assess for it, survivors are going to tell you that that's been part of your experience. And so I think important to have, because it protocolizes asking about it, but you also have to train providers to have that response, because then you have an influx, you have those 500 survivors who you want to be able to adequately respond to, which is very different, obviously, I'm sure, than the 8 to 10 originally.
Correct. You have to have it in place. If you're on a screen, you got to have a response in place for that question, and so we have that team as well. And in response to Dr. Grossman's point, I appreciate having a culture of physicians who will respond and do it. Unfortunately, my trauma surgeons ain't going to happen. So having an isolated group of people who are going to respond and do the right thing I think is key to being successful in that situation.
I'm going to move over to my right. I don't know if that mic's on.
Well, we'll see. I'll just keep talking. Yes? Think so? Hi. I'm Evelyn Tomaszewski. I'm really excited and intrigued to hear about the biopsychosocial. Some might also look at spiritual approach and how important that is to incorporate it into our work. And providers and clinicians, case managers are members. We're members of the community that we serve, the community that we witness violence, be it individual and interpersonal or collective community-based violence. So I may be 2 questions or perhaps 2 comments. I'm hoping that there'll be some response. And one is, as we look at research, the importance to me is the role of a lived experience in defining and developing research protocols and identifying interventions. And while we look to the community to help us define and understand what is happening, but I also think about the lived experience of providers and clinicians. And so perhaps there's a response to this, particularly from what we've heard about from a firm, but the psychosocial, the cultural experience that I bring, that clinicians bring to their work, how has this been incorporated into our asking, in essence, for behavior change from clinicians? Has there been research, or might there be an opportunity to look at the behavior change, the modeling of helping providers in healthcare settings make a change in our own behavior, to ask questions, to respond despite of or because of our own psychosocial, cultural beliefs in violence prevention? So it's both a question and a comment. I'm hoping perhaps you know of some research that has happened or how we might incorporate that.
Any comments?
I think having physicians with a lived experience may be the best counselors. I am not aware of research into that, but it is certainly something that has value.
With regard to the lived experience piece, I do think there's some movement in healthcare to think about how we expand roles and include other team members. I think lived experience probably across the continuum of providers, but there's a model through the Boston Public Health Commission in response to mental health and trauma in family medicine and pediatric settings, where they've hired families from the community with lived experience who partner closely with the mental health clinician to provide the response, and they're collecting data. And so I think there is some movement about the importance of that, and some interventions that I know are being tried.
And I'll just say that I think, let me add, I think the lived experience of the targeted population is also a critical factor here in terms of understanding what intervention might work. We can't test interventions without really fully engaging and involving the target population in that process. It should be they should be partners in that research and in that effort. We did a randomized trial of gun safes in Alaska, in the rural Alaska, among the Alaska Native population, and we spent a lot of time with them trying to understand their behavior around guns, and as well as understanding what's acceptable, socially acceptable around storage practices, and really trying to map that out ethnographically before we even began to think about implementing the trial itself. So understanding the lived experience of the population that you're working with is also going to be critically important.
You have 3 minutes. So I could take the two of you if it's a short question and short answer, or just one and not the second. So here you go.
Thank you. My name is Laura Castellanos. I work with the American Hospital Association. I lead the Hospitals Against Violence initiative. Our focus is to really support our hospitals and health systems in understanding their role around violence prevention. One of the efforts that we have had success with is human trafficking, and looking at it as a public health crisis. And we were able to get ICD-10 codes for that this year. But my question is mostly around, one of the things that I've noticed has been successful in implementing behavioral change, if you may, at a health system, is implementing system-wide policies followed by protocols. Have you, or any of the panel, aware of any successful policies or protocols to address screening and identification of high-risk individuals for firearm injury?
That's our goal.
There you go. That's a short answer.
I think we're definitely inching toward that to the extent that you've identified high risk individuals. But then that next phase is, I think, that where we're going. And I'm not aware personally of others.
Not aware of any either.
Rebecca, you have the last question.
Yes, just a brief comment and sort of a plug for this conversation overall. Sort of echoing your comments before, Dr. Richmond, around how the local interventions need to be driven by what the local needs are. In the same way, we found when we've implemented our hospital-based programs in the past for youth violence, that the solutions, even though we're talking about this today as a medical model, which I think is really important to engage our peers, this doesn't have to be a physician-centric answer. We found that when we looked at our focus groups and when we engaged the people who were interested in this in our hospital-wide setting, actually the champions for actually doing the screening and intervention components of our violence intervention program was actually child life. we wouldn't have known that ahead of time, and those solutions are going to be different in each one of the settings. And so as this moves forward with good implementation science, we'll have to think about in each of the settings what is the best way by understanding the individual and the local environment. So thinking about this, one, as a universal solution is not likely to be the answer, and two, physicians are maybe great at raising the awareness, but don't have to necessarily be the answer for either the screening component or the intervention components. Thank you.
Terrific point, thank you. I actually think that's a wonderful way to end the panel. So I am going to do so. I would like to thank the panelists for their wonderful thoughts and comments, and we're going to pass the panel over to the next topic. Thank you so much, panelists.